Good morning, everyone. I apologize in advance. I am not a public speaker. Let's see if I can get this. Okay, so as mentioned, just a little background information. So I did graduate in May of 2017 with my bachelor's in social work from Barry University. I also graduated in the same year, December 2017, with my master's in social work, completing an advanced social work program, as well as from Barry University. I worked at the Department of Children and Family Services for a few years, gathering a lot of knowledge in youth services and elderly services team, as well as holding family cases and child safeguarding. As mentioned, I am the only medical social worker at the Health Services Authority, and my responsibility is to provide social work services and intervention to all inpatient units, excluding the behavioral health unit. I also assist with patients and their family members in the outpatient departments, such as oncology, dialysis, urgent care, and accident emergency. So the question is, what is a medical social worker? So according to the National Association of Social Workers, NASW, a medical social worker can be defined as a professional who plays a vital role in the healthcare system by providing support to patients and their families who are facing medical and emotional challenges. Although it's not stated there, my scope goes a little bit beyond that. I do provide assistance in social and financial challenges as well. The NASW explains that medical social workers are employed in various healthcare settings such as hospitals, community clinics, healthcare centers, nursing homes, and so forth. Okay, so key roles of the medical social worker in the women's reproductive health care. So we collaborate with the maternity unit and the women's health clinic. There are also prenatal and postpartum care teams to support high-risk pregnancies. So working with the referrals office, if a patient needs to, say, be airlifted via a commercial flight or an air ambulance. Also, trauma-informed care for survivors of domestic violence and sexual assault. In this area, just being mindful and utilizing CBT, acceptance and commitment therapy, which helps the patient move beyond that their negative thoughts and feelings. Also addressing maternal and reproductive health needs. So perinatal health care screenings such as postpartum depression, anxiety, when not completed by the behavioral health unit, case management services for women experiencing high-risk pregnancies, substance use, domestic abuse, or violence, as well as support groups, lactation support groups, and childcare resources. Supporting women facing socioeconomic barriers, so accessing insurance, which was mentioned earlier, financial aid, accessing food insecurity, housing instability, and employment challenges that impact health. Education on family planning, contraception, sexual health in an accessible and cultural competent manner. Advocating for policy and systematic change. Pushing for policies that improve maternal health outcomes. So last year, I believe it was March 2024, maternity and paternity benefits were extended. Before it was only 6 weeks, and now it's been extended even further. Advocating for workplace protection, like paid paternity leave, as mentioned. Creating and supporting funding for community-based programs that focus on women's health. Expanding mental health trauma support. So, integrating social workers into behavioral health. So we do have social workers, which is why they're not within my scope. But being more proactive and providing therapy and crisis intervention when needed. trauma-informed care protocols for survivors of abuse, trafficking, reproductive trauma such as miscarriage and stillbirth, community-based agencies and services for women in need of external support and assistance. It's not working. Okay. All right, so a case study. So Jean Brown is a 21-year-old single heterosexual woman who is currently working on island under a work permit in an average paying job. Jean presented to the maternity unit 38 plus 4 days out of 40 weeks pregnant and empty-handed. She had no baby supplies. With complaints of discomfort and labor pains upon checking Jean's docket, it is noted that Jean has not attended any antenatal appointments or basic ultrasounds or scans. Jean originates from somewhere within the Caribbean region and has been living on island for the past 4 years. Jean expressed that she rents a small room in a home shared with other tenants. She reports that she does not have any relatives on island and her support system is practically non-existent. Jean divulged that she and her partner separated during her first trimester and did not inform him nor anyone else of her pregnancy. Jean also shared that her child's father does not live on island anymore and already has 5 children. Thus, she would not be able to receive physical or financial support from him. Jean gives birth to a healthy baby boy the following day, but denied seeing or holding her baby at the time of delivery. Jean informs the midwife that she does not wish to see her baby and insists that she would like to put her baby up for adoption. So, this is a real case at HSA, or was, I should say. So, with my medical social work services, going through the process, I would review the chart, meet with the team, such as the midwife or the physician, meet with the patient, which would allow me to gather information, understand the patient's decision and circumstances, accessing the patient by or using a biopsychosocial spiritual assessment, providing us guidance while being empathetic and using therapy where applicable, referring the patient for services internally or externally, and then doing a follow-up or check-in, or multiple if necessary. Oh my. Second case study. So Jenny Doe is a 24-year-old heterosexual Caymanian woman in a complicated relationship. She is currently working a minimum wage job and receives rental assistance, a small studio, from the Department of Financial Assistance, DFA. Jenny is known to have developmental delays or cognitive impairments and comes from a family known to have these issues. Jenny presents to the Women's Health Clinic with concerns of her menstrual cycle, tender breasts, nausea, and bloating. After taking a pregnancy test and completing the ultrasound, it is revealed that Jenny is roughly 18 plus 5 days out of 40 weeks pregnant. Since the confirmation of her pregnancy, Jenny has not been compliant with her antenatal appointments. There have been also reports from the community that she consumes marijuana regularly. Jenny told a medical social worker, myself, that she quit her job due to lower back pain and that her partner, Thomas, would take care of her. Upon investigating, Jenny disclosed that her partner, who is a well-known 41-year-old male, has a history of being verbally, emotionally, physically, and financially abusive. Thomas is known to consume and sell illicit drugs as well. Jenny was referred to the psychologist for a mental capacity assessment and was determined that she does not have the capacity to make informed decisions. So this is also a true case study at HSA. Again, Being a medical social worker, before meeting with her, before meeting with staff, it would be an immediate referral to the multi-agency safeguarding hub. While there is not much that they're able to do, they are able to get this information ahead of time and plan accordingly for when Jenny does give birth. Again, a chart review would be completed, a multidisciplinary team meeting would be had, and we would meet with the patient to provide person-centered care, as well as meet separately to come up with a plan of action. Okay, so patients come in feeling overwhelmed, not knowing what to do, where to go, and how to cope. The complex landscape of women's reproductive health care are pregnancy. So what is so complex about pregnancy? Well, for our patients, it can be overwhelming, underwhelming. Each patient is different. There are also miscarriages and stillbirths, postpartum depression and behavioral health issues, rape and abuse, addiction, sexually transmitted diseases and infections, adoption and foster care, gynecological issues or conditions, cancer, menopause, and poverty. Poverty. I'm going to say that again, poverty. Did you know, according to the Cayman Islands Quality of Life Report conducted by the Economics and Statistics Office, 8.3% of women in the Cayman Islands express that they live in poverty occasionally. 2.6 live in poverty often, and 2.7 live in poverty most of the time. Okay. Yeah. It's a video.
What is person-centered care? Person-centered care is where health and care professionals work collaboratively with people using their services and their communities. But what does that actually mean? It means that care is coordinated, tailored to the needs of the individual, underpinned by dignity, compassion, and respect, and enables them to live a fulfilling life. Seems like a no-brainer. Don't we already do that? Actually, it's not standard practice, but it should be. Is it worth it? In a word, yes. Person-centered care can have lasting benefits. There is evidence that it improves health outcomes, care quality, and patient experience. On the professional side, it enhances staff satisfaction. If we want to adopt it, fundamental changes to care are required. So, how do we put it into practice? There are lots of things we can do to develop people's roles in health services and to unlock their person-centered potential, to get health and care services working better together, and to help people to have the knowledge, the skills, and the confidence to work differently with their health and the NHS. What is?
Okay, so why is person-centered care so important? It's very important in social work. At HSA, we currently implement person-centered care. See, I keep saying patient. Person-centered care. However, although it's implemented, not all physicians, nurses utilize it, and this is something that we're working on to provide throughout the organization, throughout each organization in the Cayman Islands and beyond. So how to better integrate social work in women's reproductive health care? Commitment to healthcare equity, data and measurement, comprehensive needs assessment, collaborative partnerships, care continuity, engaging patients in their care. So going back, person-centered care. community-informed patient-centered care or person-centered care. Patient empowerment, so detrimental. How can we, as social workers, physicians, nurses, empower the patient? By actively listening, showing empathy, and being emotionally intelligent, advocating for the patient, establishing and respecting boundaries, being culturally competent, being adaptable and flexible, providing conflict resolution. So key takeaways. Medical social work inclusion. So not just calling when an issue arises, but planning, discharge planning at admission, utilization of tools and assessments, support and advocacy, expansion of services, patients' rights and responsibilities, patient-centered care. So, in the field of social work, empowerment is paramount because our goal, or my goal, is not to only address the patient's problem temporarily, but rather to plant seeds of self-efficacy, self-resilience, and self-reliance and importantly, resilience. My goal is to ensure that patients and the community is not just surviving, but also thriving, being an agent of change. Social work support and interventions have a profound impact on enhancing the patient's health outcomes and on a multitude of levels, regardless if it is assisting with the home health care or advocating for the patient to receive insurance, or reporting physical or sexual abuse. Social workers play a pivotal role improving the lives of patients and communities' health and well-being overall. My references. Thank you.